without much further ado, I now give the floor to Marian.
Thank you very much. Thank you for that nice introduction. Thank you for inviting me to contribute to this very interesting lecture series. So I will be talking today about the link between pain, emotions, and cognition, and how these three interact with each other in a lot of different directions. So my own research is mainly in the interaction between pain and cognition, and so I will talk a lot about that. And my pain research is mainly on healthy participants, healthy volunteers, but I will also intersperse my stories with some clinical examples and about chronic pain. So I will start with explaining why psychologists are actually interested in pain and why it's important to study pain. Then I will give a little bit of background information about how we process pain, and how pain can be modulated, and then I will speak about the specific relationship between pain and emotions and pain and cognition. At the end I will give a little outlook on how we can apply some of these theories to treat chronic pain. So why is it relevant to study pain? Why are psychologists interested in pain? Well, first of all, because it's a big problem in society. So pain, and in particular chronic pain, pose a huge burden on the healthcare system and can really affect people's lives. So to give you some numbers, this is a big European survey on chronic pain and the influence of pain on people's mental life and specifically on their work life. And this is a big survey that has only recently been published this year. The results have just come out. And some of the conclusions from this survey are quite impressive. So they estimate that about a fifth of adults in Europe suffer from chronic pain. That means that about 95 million people are currently living in Europe with suffering from chronic pain. And this figure is likely to even increase because of the aging of the population. So elderly people suffer more often from pain, and so this number is going to still increase. Patients themselves, chronic pain patients, report a considerable reduced quality of life. So chronic pain is also considered to be one of the main causes of disability. Half of patients cannot carry out their job, so of course this has huge implications for society. Chronic pain is also the most commonly reported reason for self-medication and for accessing the healthcare system, and so obviously this has a direct influence on social care budgets. So the total cost as a consequence of chronic pain on the social care budget is estimated to be as high as 300 billion euro. So pain is a huge problem for individuals and for society, but why should we care as psychologists? Isn't that a problem for physicians or for medical professionals? Why should we care about pain? Well, pain is not just simply a sensory event. Pain is a very subjective experience, and often there is no straightforward relationship between the amount of tissue damage and the amount of pain that we feel. So pain is very strongly influenced by emotions and cognition. And this is something that is quite obvious and has been observed for a long time. So a very important observation was already done in the Second World War by an anesthesiologist called Henry Beecher. And he observed that soldiers suffering from battle wounds often report very little or no pain, and they request fewer analgesics, fewer painkillers than people undergoing surgeries with a similar amount of injury. And so it's very clear that there are factors that influence how much pain we feel. And we now know that emotions and cognitive factors are mainly involved in this. And so, for example, things like fear, depression, anxiety, or stress as emotional factors have a huge influence on how much pain we feel. And cognitive factors such as attention, expectations, memories, and beliefs or thoughts we hold about the pain can really alter our pain perception. Also, chronic pain conditions are strongly linked to these factors. And so psychologists can contribute to understanding pain better by studying these factors, these emotional and cognitive factors. And this may lead to develop psychological treatment strategies for chronic pain as well. And this will become hopefully more clear later in the talk. So before I start to talk about the role of emotions and cognition, I'm going to give you a little bit of background information about basic pain perception, how it's processed in our bodies and brains, just to have a bit of background information. So, as we all know, pain actually has a very important function, namely as a sort of warning signal, an alarm function. It's our warning signal for potential tissue damage, and it functions to interrupt ongoing activities. So it triggers behavior that helps us to heal the pain, protective behavior for the body. So how important this warning signal is becomes clear in patients who have something called congenital insensitivity to pain. This is a genetic mutation that affects the development of pain receptors in the body. And so people who have this condition are unable to feel pain. They have no pain sensation. They have normal sensory perception. They feel touch and pressure, but no pain. And this often leads to really a lot of problems. So they often self-mutilate, means that they get all kinds of injuries that they accidentally afflict to themselves. So they will bite their tongue and not realize. They may break bones and not realize. And the fact that they don't realize means they're not paying attention to it. And so healing is often very slow. And so they may also, for example, have all kinds of infections that they don't realize. And so these people often have a very reduced lifespan, which shows you how important it actually is to feel pain. So how is pain processed in the body? Well, pain processing is also called nociception. And the pain receptors in the body are called nociceptors. And these are everywhere in the body. So you have a lot of them on the skin, on tissue surfaces, and in the joints and bones. A bit fewer in the intestines and muscles. And an exception is in the brain. In the brain itself, there's no pain receptors. So the brain itself can't feel pain. But the experience of pain is generated in the brain. So yeah, this is just to illustrate very briefly that that these pain receptors are very specific. So we have receptors in the body for normal, for example, normal temperature perception or normal mechanical perception. Mechanical would be like pressure or stretching. But these pain receptors, they specifically respond to stimulus intensities that are potentially dangerous, potentially harmful. So when we record directly from a nerve, an axon from a pain receptor cell, then we see this kind of pattern. So a normal thermoreceptor cell, a normal cell that responds to temperature, responds from a very low intensity and then flattens out, so reaches the maximum response rate at quite a low temperature. So our pain threshold is often around 45 degrees, and you see that these specific pain receptors only start to respond at a very high intensity and are also still responsive at higher intensities above the pain threshold. So these nociceptors are really specific receptors for the sensation of pain. So what happens after these nociceptors detect a potentially dangerous stimulus? So for example, here we have a wound in the finger. Once these nociceptors respond to it, they send action potentials through an axon to the spinal cord. So this is like a cross section through the spinal cord. They enter the spinal cord in the so-called dorsal horn at the back, where they connect with secondary or second order neurons that then cross to the other side. So generally the left side of the body is responds to so the right side of the brain responds to the left side of the body and the other way around. From there it goes through the brainstem to the brain. I'm talking faster than my PowerPoint slides. So in the brain, these signals first reach the thalamus, which is an important relay station for sensory input to reach other areas in the cortex. And from the thalamus, pain signals are being transferred to a lot of different areas in the brain. Now this is a very simplified, very much simplified image. It's no point going into it deeper, but just to tell you that there is actually a lot of other pathways involved and other connections involved that are not shown here. But very simply said, this is how pain signals from the body reach the brain. And then in the brain, and there's a whole network of areas that are involved in pain processing. And this is sometimes referred to as the pain matrix. So this picture was made on the basis of a lot of neuroimaging review studies and depicts the areas that are most commonly activated in response to pain stimuli, to acute pain. And the interesting thing here is that there's not only areas involved that encode sensory aspects of pain, but also areas that respond to the emotional and the cognitive components of pain perception. So we have the blue areas, which are part of the so-called sensory or discrimination component of pain perception, and in particular the thalamus and the primary and secondary somatosensory cortices. So these areas, they are responsible for identifying the location where the pain is, for the intensity of the pain, for the type of pain, whether it's thermal pain or pressure pain. So all the sensory characteristics. And these areas also trigger, for example, withdrawal reflexes to prevent more damage to the system. The orange areas are part of the so-called affective or motivational dimension of pain and involve the insula and the ACC. This is an important one. This is the anterior cingulate cortex, and I'll be talking about this much more in the rest of the talk. And so these areas are specifically involved in the emotional reaction that we have to pain. And for example, the anterior cingulate cortex normally is also involved in a lot of other different kinds of processes to do with emotional processes and stress and motivation. The green areas, so here it's only the prefrontal cortex, but the ACC is also a bit involved in this. So these are areas that are involved in the cognitive dimension or the evaluative dimension of pain perception. So the interpretation of the pain and the more evaluative processes to do with pain perception. So these three dimensions of our pain perception were already defined very early by Melzack and Casey, and now there is neuroimaging evidence as a biological basis for these three components. So you really see that emotions and cognitions are an integral part of our pain experience. So now I've covered basic pain processing, how pain stimuli are being transferred from the body to the brain. But now I'm going to talk a bit more about how pain can be modulated. And the observation that when you have pain somewhere, a sort of instinctive reaction is to rub the area where you have pain, and this often relieves the pain. And this observation has led to a very important theory called the gate control theory. And this was already coined in 1965. So generally this theory poses that pain can be modulated or can be altered at the level of the spinal cord. So in the spinal cord, you have these different types of fibers. So you have these fibers are just normal sensory fibers for normal sensory perception, normal temperature perception, for example. And C fibers are a type of pain fibers. And in this picture here, you have these interneurons, and these are very important. They are inhibitory. And when these non-pain, these sensory fibers are activated, they can activate the inhibitory interneurons and thereby reduce the pain processing in the spinal cord. So basically, non-painful sensations can close the gate to pain and reduce pain perception at the level of the spinal cord. This theory is by now a little bit outdated, so we now know that it's a little bit more complex than this. But the important point is that this theory has triggered a lot of interest in the field of psychology of pain, and has triggered a lot of research in pain modulation. And interestingly, we now also know that this kind of inhibitory inhibition of pain signals can happen by top-down processes. So it can happen triggered by the brain without any external input. And this is through the so-called descending pain control system. I promise this is the last sort of anatomical image. Afterwards it will be a bit less complicated. So, but basically you have the so-called ascending pathway on the right, so where pain stimuli are coming from the body and being transferred to the brain. And in parallel, you have a pathway that's going exactly the same route down. So from the brain down to the location of the first synapses in the spinal cord. And so this is very important because it means that this provides the basis for how the brain itself can reduce or enhance pain perception. So this descending pain control system can either facilitate or enhance pain, or it can inhibit or reduce pain perception. So in terms of the brain areas that are involved, the two areas that are very important here, that are not actually indicated on this picture, but the prefrontal cortex and the anterior cingulate cortex. These two are sort of the main brain areas that can trigger this descending control. And another very important one is this PAG, stands for periaqueductal gray, and it's in the brain stem. So it's the sort of the brain stem is the link between the spinal cord and the brain, and is involved in a lot of very important basic regulatory processes in the body. And all this descending control always goes through the periaqueductal gray area, the PAG. Okay, so a little bit about chronic pain. Chronic pain is defined as pain that lasts at least 3 months. That's a bit of an arbitrary definition. Actually, the official definition of chronic pain that is endorsed by the International Association for the Study of Pain is that chronic pain is pain that persists past the healing phase following an injury, but that is a bit difficult to determine what the healing phase is. So the common consensus is clinicians often use this 3 months as a sort of arbitrary cutoff. Sometimes they say 6 months, but yeah, this is how chronic pain is defined. So a key characteristic of chronic pain is that the cause is often very difficult to determine. So often there is no actual lesion in the body, no injury that is related to the pain. And so the experience of pain in chronic pain doesn't correspond well with what's happening in the body. And pain in these conditions is no longer a useful warning signal. Pain becomes like a disease state. So also what causes pain, chronic pain, is very unclear. It's not well understood, so there's a lot of research on this and a lot of theories that are being proposed. People have come up with a lot of factors that supposedly play a role in the development of chronic pain, and it's very complex. But so far, no theory has been able to really explain the whole story. And probably there's different mechanisms for different kinds of chronic pain conditions and for different patients. But now researchers have started to look at the brains of chronic pain patients, and that's been a bit more informative. So a very recent insight is that chronic pain may be related to this descending pain control mechanism in both senses. So there is some evidence that the facilitatory pathway is sustained, so there's constant enhancing of the pain, and at the same time the inhibition is reduced. So normally when people feel pain, there is probably both these pathways are activated and they're somehow in balance, but in chronic pain, maybe due to structural changes in the brain, these two pathways are imbalanced, and so there is constant reinforcement of pain and reduced reduced inhibition of the pain pathways. So this also means that therapies that are targeted towards this descending pain control system are becoming more and more important, and I'll say more about that later. So this also ties in with a project that we're currently doing in our lab. So this project looks at this descending pain control system in chronic pain patients, and specifically pain patients that are treated with spinal cord stimulation. This project we're doing in collaboration with the main hospital in Luxembourg and with a company called Nevro. And they produce these spinal cord stimulators. Now, what is this spinal cord stimulation? That is a treatment, a therapy that's been used for a long time, whereby they insert a small electrode directly in the spinal cord of patients, and it's connected to a pulse generator, one of these, via a lead. And this whole system is implanted, so it's completely invisible to the outside, and it's controlled by a remote control. And this electrode delivers very little electrical pulses to the spinal cord. And this therapy has been developed as a reaction in a way to the gate control theory, which stated that non-painful sensations can sort of close the gate to painful sensations. They can inhibit the transmission of pain signals to the brain. And so the thought was, if we give these non-painful sensations from the outside by means of electrical pulses, we can stop this pain transmission to the brain. And so this originally these kind of spinal cord stimulators would evoke a tingling sensation in patients. And this tingling sensation would then mask the pain, and sometimes it has really impressive results. So it greatly reduces pain in patients who are otherwise unresponsive to pain medication. But now the technology has improved a lot. So the first stimulator was already implanted in 1971, and by now they use the same principle but a different stimulation technique. So they now give very high frequency pulses, And somehow this does not evoke the tingling sensation, but it still reduces pain perception in these patients to a very even more than the tingling sensations would do. And so this is kind of strange because it means that the gate control theory doesn't explain the whole story. And so there is now some evidence that it may have something to do with this descending inhibition system. So the spinal cord stimulator is thought to somehow restore the function of this descending pain control. So in this study that we're doing, we're testing patients before and after implantation of this device, and we're testing the descending pain control pathways by means of non-invasive standardized protocols involving simple acute pain stimuli. And what we're hoping to see is that before implantation of the device, patients show a reduced inhibition, and that this inhibition of pain is normalized with the treatment, and also that the facilitation is probably increased before implantation and is normalized through the treatment. Okay, so far about pain perception itself. In the next part I will focus on the link between pain and emotions, and first about how pain influences emotions. Now I think this is the most obvious of all the connections, because pain is by definition an unpleasant experience, so pain induces negative emotions. We've already seen these three components to the pain experience, the sensory, the emotional, and the cognitive. And so the emotional component is an integral part of pain perception. This I'll go through quickly, so just to show that studies on pain and emotion have really exploded, especially in the last few decades. So the research, this is the number of studies that have a title which contains both pain and emotion or affective. And this research started shortly after the gate control theory was posed, with a sharp increase in studies with the birth of sort of neuroscience, so people starting to look at emotional processes in the brain. Okay, so we've already seen that pain activates regions in the brain to do with the sensory components and with the emotional component. And these pathways or networks can also function more or less independently. So they're really separate pathways that can function independently. And this is nicely illustrated by clinical cases in which there's damage either to one system or to the other, which leaves the remaining system intact. And this is also called a double dissociation. So on the one hand, you have a few clinical cases are known where the sensory system is impaired. And so these are scans of a patient who has had a stroke in the right side of the brain, in the parietal cortex, where the somatosensory areas are. So these are specifically regions that are responsible for the sensory discriminative processing of pain and of the hand region. So this patient has lost all sensations in the left arm and hand, and has normal sensations on the right side. And when they test this patient, they gave him painful stimuli by means of an infrared laser, so heat stimuli, heat generated through laser. And on the right side, he had very normal responses, but on the left side, he would not report pain. So even at very high intensities, if they stimulated his left hand, he would not say that he felt any pain. And even if you urged him, he could not describe the intensity or the location of pain. But at very high stimulation intensities that are normally far above the pain threshold for people, he would spontaneously describe a clearly unpleasant feeling, but he couldn't say where it came from. He said somewhere between the fingertips and the shoulder there is something unpleasant, and he wanted this to stop. He wanted to avoid this feeling. So that shows that the emotional component can exist without any perceptual, any sensory element. And on the other hand, the inverse can also happen. So they used to sometimes treat chronic pain patients by destroying the anterior cingulate cortex. This is a very important area in pain perception and also pain modulation. And they did this originally to treat psychiatric conditions, but they also, in the early 60s, they started to do this with chronic pain patients as well, because they noticed that it has a profound effect on pain perception. And so this is called cingulotomy. And now, of course, it's becoming less popular because we have a lot of other treatment methods. But it's still sometimes performed in very severe chronic pain patients who have not responded well to any other therapies. So the way they do this, so Foltz and White were the first to perform this operation with chronic pain patients in 1962, and back then they performed this operation guided by X-ray images of the brain. Nowadays they would do it with MRI images, but here you see X-ray images where you see the electrodes that they stick in the brain. So it sounds it is as bad as it sounds. So they stick so-called thermocoagulation electrodes in the brain after drilling some holes in the skull. And these electrodes heat up and they literally burn this part of the brain that they target, the anterior cingulate cortex. And here you see the resulting lesions. So this is an MRI image with a transversal section of the brain where you see these two lesions very neatly localized in the anterior cingulate cortex. This report from 1962 is quite hilarious to read, actually. The way they describe the surgery and the patients is quite funny. So they write that they could. So generally, patients recover surprisingly well from this intervention, and they can leave hospital after a few days and go home and resume their normal activities. And sometimes they have no side effects at all. Sometimes they have some cognitive problems, but these usually disappear after a few months. So I'm going to read some funny reports that they have about these patients. So about one subgroup of patients with a specific type of pain, they say all 6 patients had long-standing complaints of pain that were incapacitating them for useful existence. 1 excellent result, 3 good results, and 1 fair result occurred in this group. Only 1 has died, presumably poisoned. So presumably it had nothing to do with the surgery. Also, they say in all instances, social activities thereafter were quite acceptable, except for case 3, whose social activities had always been a bit bizarre. So again, suggesting that it had nothing to do with the surgery. They don't specify anything. But anyway, the important point about these case studies is that all these patients, they actually improve massively. So they often, after being debilitated by pain, they can lead normal lives again. And most of these patients, they state that they continue to have pain, but that they're just not bothered about it anymore. So they don't worry about it anymore. It doesn't bother them anymore. And so this emotional component to pain is just gone, with the sensory component still there. Okay, so a little bit more about how pain influences emotions. In chronic pain, there is a high comorbidity between with emotional disturbances, with psychiatric disorders, so mainly depression and anxiety. Yeah, just very briefly, this is an example of a big survey that they did quite recently across in many countries in the world as part of the World Mental Health Surveys. And so it was a huge sample of over 85,000 participants with whom they did face-to-face interviews to assess depression and anxiety. They checked their pain experience or chronic physical conditions by means of questionnaires, and then they analyzed the association between these. And I don't know if you can read it in the back, but anyway, there's a lot of different types of physical chronic conditions, of which only these in the red box are pain conditions. This table gives odds ratios, so like the probability of an association, the likelihood of an association between depression and anxiety, either depression alone, anxiety alone, or both, and all these different conditions. And you see that the pain conditions in particular show a very high association with anxiety and depression, and especially with both at the same time. And these patients, they have poorer health outcomes, so they have a poorer diagnosis and respond less favorably to rehabilitation. So it's very clear how pain induces negative emotions, but the arrows also go the other way around. So emotions can influence how we feel pain, and this can be either a negative or a positive influence. And so this is a bit of a hypothetical graph depicting the influence of emotions on pain. Here you see the kind of modulation. So the red part is pain facilitation, where you have enhanced pain, and here inhibited pain. On the horizontal axis, we have the arousal or the intensity of the emotions. And you see that positive emotions, they generally decrease the pain experience. So people in a good mood feel less pain. And the stronger the emotion is, the stronger the arousal, the more decrease in pain there is. And with negative emotions, we see the inverse pattern. So it increases pain the more the intensity is, the more the intensity of the emotion. Except for when the intensity of the negative emotion is very strong, then you can actually have a reduction of pain. So this is in cases of, for example, extreme fear or panic. Then this can actually reduce the pain experience. But this general pattern of reduced pain associated with a good mood and enhanced pain associated with enhanced pain associated with a bad mood and reduced pain associated with a good mood is also reflected in studies. So, for example, this study by Rudy and colleagues, they have they have shown participants pictures that were either pleasant or unpleasant or neutral, and they stimulated the sural nerve, which can trigger a pain withdrawal reflex, and then they measured the activity in the leg muscle to quantify this pain withdrawal reflex. Now, this reflex is mediated by spinal pathways, so the brain has no influence. It's only a process in the spinal cord, but this can be influenced by top-down processes. Participants. So while participants were viewing these either positive or negative pictures, they received painful electrical stimuli to their ankle, to the sural nerve, and then they had to rate their pain on a visual analog scale. And what you see is very clear. So for unpleasant, so here we have unpleasant, neutral, and pleasant pictures. And the unpleasant pictures, the pain ratings are much higher than for the pleasant pictures. So there's a modulation of the pain ratings. But interestingly, the same modulation happens for this reflex. So the pain is not only influenced in terms of the evaluative component, but also the spinal processing of pain is influenced. And this suggests that, again, there's this involvement of the descending pain control pathway. Okay, so this becomes even more clear in a series of studies by Villimer and Bushnell. They did fMRI studies, and again they showed participants pictures. No, they induced negative and positive moods by pleasant and unpleasant odors. So they had a little plastic tube leading to the nose of participants lying in the scanner, and they administered odor stimuli by a computer. So there were very computer-controlled puffs of air coming to the nose of participants lying in the scanner, and they had, for example, odors like rotten fish smell and flower smells. And at the same time, people got pain stimuli on the leg with a thermode. A thermode is a device that can give very controlled heat stimuli, controlled by a computer. And so again, they find these same behavioral results, so higher pain ratings for bad mood states and lower pain ratings for good mood state. In this case, only the unpleasantness ratings of participants were reduced significantly, but there's the same trend for the intensity ratings. And interestingly, in the brain, we see the same results. So the gray areas, they are areas that are reduced in good mood versus bad mood. So the areas responding to the sensory aspects of pain are less active when patients are in a good mood than when they're in a bad mood. And the green areas are more active during good mood than bad mood. And these, the anterior cingulate cortex and the prefrontal cortex, those are the important regions that are involved in this descending pain control. So the emotional modulation triggers the descending pain control pathway. So if emotional modulation of pain depends on the descending pain control system, and the descending pain control system is impaired in chronic pain, then we would also expect this emotional modulation of pain to be impaired in chronic pain patients. And this is exactly what has been found in some studies. So these are fibromyalgia syndrome patients. Fibromyalgia is a type of chronic pain that is characterized by widespread pain all over the body without a clear cause and healthy controls. And we see here the same modulation in healthy controls, so higher pain ratings for negative mood and lower pain ratings for positive mood. And the inhibition of pain in a positive mood is not there for chronic pain patients. So this suggests that there's impaired inhibition in chronic pain. So the emotional modulation in chronic pain is disturbed, and we've seen that there is a high comorbidity with affective disorders, but it's not actually clear whether these conditions were caused by chronic pain or whether they may precede chronic pain. And so we have a bit of a chicken and egg problem. We don't know in which direction the relationship goes. And there's a lot of discussion in the literature. And at the moment, it seems like there's more and more evidence that it may actually be the case that these factors are a risk factor for the development of chronic pain. So the disturbance in the descending control may precede the development of chronic pain. But however it is, whichever direction it goes in, it is the case that these kind of negative emotions and pain interact to create a sort of vicious circle. So pain-related worries and emotions, they make the pain worse, which can fuel worrying about pain and creates negative emotions and reinforces itself. Okay, so I'm have to go relatively quick because I've been speaking much more than I thought I would. So now a little bit about cognitions, how pain influences cognitions. This is based on the premise that pain captures attention. So since pain is such an important warning signal, it involuntarily and automatically grabs our attention. And we have only limited amount of attention, so we have a limited attentional capacity. And therefore, when we feel pain, there's less attention left for ongoing cognitive performance. And so in this hypothetical graph, when it's like a trade-off. So when there is not so much attention grabbed by pain, when the pain is not very intense, there is still relatively more left for cognitive functions. And so this may lead to relatively good task performance, whereas the other way around, if pain is bad, it grabs a lot of attention and leaves little left for cognitive functioning. And this is also reflected by experimental studies. So you see in this study clearly this linear relationship between the pain ratings, the amount of pain perceived, and performance on an NBAC task. So the higher the pain, the lower the performance of this NBAC task. NBAC task I will get back to in a moment. So this is in laboratory studies where pain is induced experimentally in participants and in a very controlled environment. But this doesn't mean that we still don't know whether pain actually influences cognitive performance in a more realistic setting. And so in this study, they did a big internet study where they recruited people online and they filled out questionnaires about whether they were having pain or not. And then they performed this NBAC task, in this case a 2-back task. So participants had to say if a letter that appeared on the screen was the same letter as 2 presentations back. So a series of letters, one after the other, was presented on the screen. And participants had to say if the letter was the same as 2 back, which is a very demanding task requiring updating of working memory. So in the people that responded to this study, we see that about 40% reported to have some amount of pain, of which about half were classified as chronic pain, and most of those were having either backache or headache. And they compared people with pain and without pain in their performance on this task, and people with pain performed much worse than people without pain. So this confirms these laboratory studies and confirms that it's also pain also negatively influences cognition in a more naturalistic setting. This becomes even more clear for chronic pain. So chronic pain has been associated with a lot of cognitive problems, including concentration problems, memory problems, problems with working memory and emotional decision making. So finally, we will look at how how cognitive factors can influence pain. I'm sorry, I'm still not done, but I will try to go through it a bit quickly. So there's many cognitive factors that can influence our pain perception, and one of them is beliefs, so thoughts we have about the pain. If we think that pain is very threatening and very dangerous, then it's going to be more intense than otherwise. We also have prior experience, so you always compare pain to previous experiences. Catastrophizing is a personality trait that has to do with worrying about pain, which can also very negatively impact on how much pain we feel. And then there's 2 factors, expectations and attention, that I wanted to say a little bit more about. So attention is pain demands attention and interferes with task performance, as we've seen, but of course the inverse is also true. So concurrent mental activities can distract us from pain. And in fact, distraction is one of the most commonly used coping strategies for pain. In this example, I would actually be that scared to be strapped with a device in my eyes, but you can see that youth nowadays, you give them a screen and everything is fine. So what are the neural mechanisms of the distraction effects? Well, they've done neuroimaging studies whereby they, in a very similar paradigm, they have people perform a cognitive task, and then at the same time they give them pain stimuli in the scanner, and this reduces the pain ratings, so the pain intensity and unpleasantness ratings go down. But very impressively, the activity in the brain also is strongly reduced. So in this top row, there's the brain activity associated with the no distraction condition. So people perceive pain, and you see the usual pain matrix activated, so all these areas that we've previously mentioned. And here is the distraction condition. So you see that really throughout the brain, there's less pain-related activation. So distraction really reduces the pain experience. And again, the important thing here is that the PAG is involved. So again, distraction may work by triggering this descending pain control. And distraction may actually reduce pain signals before they arrive in the brain. So this is a study that we're doing currently in our lab to investigate a bit more about the mechanism, the underlying mechanism of distraction. So we know that the prefrontal cortex is very important in triggering this distraction effect, but what is the psychological function that underlies this? And so what we're doing is to have a distraction paradigm of people in so people are doing a cognitive task and are being stimulated, they get pain stimuli at the same time. And we're measuring their selective attention skills or inhibition skills by means of this task, which is a task whereby people have to indicate the direction of the arrow in the middle, and they're being distracted by the flanker arrows on the side. So it's a task that is about how well people can inhibit distractors, and this is relevant to this pain distraction paradigm as well. So if our hypothesis is that if people are able to do this task well and are not much distracted by the flanker items, they may also be able to focus well on a task and not so much be distracted by pain. And this is basically what we find. So I'm sorry, I have to go very quick, but we find a correlation between this selective attention skill, or the how well people perform on this distraction ignorance task, and how much distraction people experience in a pain paradigm. And we're now also doing a study to see how distraction is working in elderly, because elderly may actually benefit less from distraction, because they we know that aging is associated with reduced attentional abilities, and with atrophy of the prefrontal lobe, which triggers this distraction effect, as we've seen. And so we suspect that elderly may benefit less from distraction, and so we're doing a study to investigate that. I think I'll just go through this because we really don't have time. I'm sorry, I misjudged how much it would take us. Maybe a little bit about the placebo effect. So the placebo effect is again something that is a cognitive influence on how much pain we feel. So purely by expecting an improvement in our pain, we experience actually less pain. And again, we've done a study in our lab where we looked at the placebo effect in the scanner. So participants were they received different creams on their arms, and we told them that one of the creams was a powerful analgesic cream containing lidocaine, a powerful painkiller, and the other cream was a control cream. And we gave them pain stimuli on these different patches that were treated with these creams. In a first manipulation phase, we actually, without participants knowing, we gave them lower pain intensities on the patch with the supposedly painkiller cream and higher intensity pain on the control patches to reinforce the expectation of pain relief. And in a test phase, they received similar pain stimuli on both patches so that any difference in pain ratings between these two can be attributed to the placebo effect, to their expectation of pain relief. And so we found reduction in pain ratings, so people perceived the pain as less painful when they thought that the cream was contained a painkiller compared to the control patch. And we also found similar results to this distraction study in the scanner. So again, we find less activation in the brain in pain responsive regions, but more activation in the prefrontal cortex, again suggesting that the prefrontal cortex is triggering this descending pain control. And very importantly, the prefrontal areas that are active in this paradigm were co-activated or functionally connected with the periaqueductal gray. So this is really a very strong hint that the descending pain control system is again implicated in the placebo effect as well. So I'm just going through to the last slide. So we've seen that in chronic pain, the descending control system is impaired, and as a consequence, emotional and cognitive modulation of pain is impaired. And so there is also evidence that the impairment in the descending pain control may precede the chronic pain, and so of course, physicians are becoming more interested in targeting this system to treat chronic pain. And so more psychological approaches to treat pain are becoming more and more popular. And there's a little bit of evidence, very recent, that these psychological approaches to treat pain may actually reverse the changes in the brain due to chronic pain, or that can be seen in chronic pain, and that they may restore this descending pain control. And so examples of these kind of approaches are meditation and hypnosis, and they've been shown to change activation in these brain regions that are involved in pain perception, and even so people who meditate a lot, for example, they even show structural changes in the brain that reverse these changes in chronic pain, and so they may have long-term functional consequences. The same is true for mindfulness as a treatment strategy. There's cognitive behavioral therapy, emotion regulation strategies, and one I wanted to mention is real-time functional neurofeedback, but unfortunately there's no time. So I'm very sorry, but I'm just going to finish with the last message. Thank you so much for sticking with me, and sorry that I had to go through so quickly in the end, but thank you for listening.
Well, thank you very much, Marian, for this highly interesting and inspiring presentation. I think we have room for 2 or 3 questions. But first, let me say that what I learned is physiologically, neurologically, and also from an evolutionary perspective, it makes sense to say yes to pain.
To say yes to pain?
Yes to pain.
I'm not sure if I agree with that, actually.
With regard to attitudes, for example, that you showed that having the right attitudes and accepting pain, I'm not talking chronic pain patients, for example, it makes sense. And evolutionary, it makes sense to accept pain as an important thing.
Yeah, that is true, yeah. It's just a bit of a bummer if you have chronic pain.
Yes.
Evolutionary, you were that when you had long pain.
Yes, but
Not true nowadays any longer.
that's what. Okay, yes.
I have a question. So sometimes you read about these people who endure crazy amounts of pain, like they walk through fire or something. So I think for those people, it's pretty obvious that this is due to cognitive and emotional factors because they actually train for these things. But so for normal, healthy people, is there also differences in the level of pain tolerance? And is this due to also biological factors? So maybe, I don't know, the nociceptors, the amount that we have,
Yeah.
or is it all emotional and cognitive?
It's not all emotional and cognitive. It's very difficult to determine what exactly is due to maybe physiological factors and what is due to emotional factors, because you can never really control what's happening in someone's mind, even though laboratory studies are set up to be very, to control for these factors. But yes, I think there's also physiological changes. So people's pain thresholds differ a lot. And they change with age, for example. So with aging, we see that people become a little bit, for some types of pain, they become more sensitive. For other types of pain, they become less sensitive. So yeah, that does play a role as well. But I think that the influences of emotions and cognition are really big, actually.
More questions? Yes.
Did you know for the online 2-back study, did they ask about the pain before they did the task or afterwards?
I think they did it afterwards. Okay. So yes, this is a...
I was wondering if you focus on the pain, then does it more inhibit your cognitive abilities at that moment because you were asked about it?
Yeah, this is always a very difficult thing. So if in these kind of pain distraction paradigms, you of course want to evaluate how much pain someone is feeling, which forces you to instruct people to tell you how much pain they are feeling, which means they are going to pay attention to the pain, even though you want them to be distracted. So this is a problem, and people have circumvented this problem by different ways of dealing with it. So one way is by only asking people to rate their pain at unpredictable intervals, so that they don't expect it and they hopefully don't always pay attention to their pain, but they're sometimes cued to rate the pain, or by asking people to only after the experiment, after the paradigm has finished, to indicate in retrospect how much pain they felt. But of course these have limitations, because then you're not really asking to rate the pain, but to rate the memory of the pain. And so it's very difficult, yeah.
Also because the cognitive task then, of course, extracts from the pain, and then the rating can be lower than it would actually be at that moment.
Yeah, this probably...
Talking about distraction, you said that this is something that we all know. When we hurt ourselves, for example, that we we hit ourselves while leaving the room, for example. One thing that we do is we rub the part, and that was also explained or tried to explain by this gate control theory. I know that Richard Stevens did several years ago. He did a study that swearing also helps.
Yes.
And this is the other thing that we all do. It's like, what the hell?
Yeah.
So how do you explain that?
I think swearing probably has an influence on negative emotions, so it probably relieves some of the frustration or tension. I guess I would explain it in that way. So I would say it's reducing the negative emotions and thereby reducing the pain.
Okay. Thank you very much, Marian.
Thank you.
Thanks.